Welcome to the Low Carb MD podcast. No one is beyond help. No one is beyond hope.
As we have always said, we are bringing you medical information and cutting-edge science, but none of this is medical advice. Please seek out input from your own doctor.
Hello and welcome back to the Low Carb MD podcast. Tro, how are you doing, man?
I'm doing great. This is going to be really exciting. Somebody's story who's very inspiring. One, just a brilliant cardiothoracic surgeon who's been, and a story I relate to actually, brilliant cardiothoracic surgeon helping people, saving lives, and finds himself, morbidly obese following the guidelines, and then takes his health back into his own hands by following the non-convention. Brian, where have we heard that story before?
Yeah, and I mean, Tro, it is amazing. When I met this doc, I was like, you're a cardiothoracic surgeon and you're doing low carb, and like everyone says everyone's going to die of heart attacks and strokes when they go on this kind of lifestyle, and you are seeing the benefits. So I was like, wow, this is pretty interesting. We met at a conference, and I was like, I was blown away. And I saw a couple cardiothoracic surgeons and a bunch of cardiologists. Like, wow, this is it's not just Brett Scher out there talking about this stuff. There's a lot of people, a lot of cardiologists we know, Tro.
Nadir Ali, Christian Assad. Yeah.
Yeah, and so it's amazing.
Yep.
And there's more and more coming out of the woodwork. And so I think people are seeing outcomes and looking at it and saying, okay, let me reassess. So the great docs are the ones who reassess and say, let's see what our patients are showing, what our numbers are showing. So Tro, no one wants to hear us talk. Let's get
Dr. Philip Ovadia. Thank you for coming on. Thank you for taking the time. Very honored to have you on. And maybe we could start off by saying how is it that you got to low carb? What happened? Can you tell us a little about the origin story?
Sure thing. And just before we begin, I want to thank both of you, Brian and Tro, for having me on. This is truly an honor. As we get into my story, one of the things is I've just learned so much from listening to all your podcasts, listening to, the contribution you guys have made to the community. And thankfully, I got to see you both talk last year at Low Carb Boca. And that was just a great experience. So, my story is, eerily similar to you, Tro. I mean, I was obese most of my life growing up. I grew up in a household that we did all the right things by the guidelines. We ate low fat. We had margarine instead of butter. We always drank skim milk. I have a brother who is a type 1 diabetic, so we didn't have any sugar in the house. We had all the, the healthy whole grain cereals. And, I was very active as a child, played a number of sports, oftentimes rode my bike or walked to school, and just was always a big kid. And then I got to college and gained the freshman 15, and then I think the sophomore 15 and the junior 15 and the senior 15 on top of that. Went to medical school. And as we all know, just crazy life then, and not sleeping and not eating well and in the hospital all the time, and just kept getting bigger and bigger. The first time I remember, really realizing my struggle was, I was going into my chief resident year as a general surgery resident. And one day I was walking around, making rounds, walking around the hospital, and I developed the worst chest pain. I thought I was having a heart attack on the spot. And there I was, 25, 26 years old. And I was probably 260 pounds at the time. I'm only 5'7", so I was big. And I said, I got to do something about this. And like everyone else, I said, how do you lose weight? You eat less and you move more. So I doubled down. This was back in the day. Tro's too young, but Brian will remember I just got in my first Palm Pilot and downloaded a program and tracked all my calories and, made sure I was sticking to 1,300 calories a day. And between cases, I started going to the gym at the hospital and, would be on the treadmill for an hour. And and it worked. I lost weight. I probably lost 50 or 60 pounds. And I remember, our graduation dinner for residency that year. The big joke going around was Dr. Ovadia was the first person to come into this to leave this program as less of a man than he came into the program. And, I kept the weight off for a little bit, but then life happened again and I gained it back and more, and went through a couple more cycles where I would, double down and eat less and lose some weight, and then just kept gaining it back and gaining more. And, a couple of fortuitous things happened to me. I, first of all, I met my wonderful wife, and we had two great children. And after my wife had our second daughter, she had the worst heartburn. She could not get rid of it. She was, popping all the medications and Tums and PPIs and all that. And someone suggested to her that she go gluten-free. And me being a, kind of bullheaded, standard trained surgeon, I said, well, that sounds a little crazy. You don't have any, allergies, you're not celiac, but if you want to try it, I'll try it with you, being a supportive husband. And so we went gluten-free, and this was probably about 6 years ago, kind of before they had all the substitutions, and it was unintentionally low carb, but basically I noticed right away how much better I felt. I had more energy. I wasn't falling asleep in the afternoon in my office, and I didn't really lose any weight to start with, but just kind of noted it, but it didn't really trigger me yet. And then a few months later, I was out at our annual cardiothoracic surgery meeting, and Gary Taubes happened to be the invited speaker that year. And, again, you know how these meetings are, 2,000 docs sitting in the auditorium. And, I'm kind of in the back going, why do we have this guy here talking, again, being the sort of traditionally educated, closed-minded doctor at that time. And he started talking, and it just clicked. He started talking about obesity and sugar and carbs. I read both his books at that time on the plane ride home. And, that's where I started low carb and low sugar. And then over the years, it evolved to keto, and for the past 18 months, mostly carnivore. And I've now, lost over 100 pounds, have kept it off for, 4+ years now. And then, as you guys know, once you see it, you can't unsee it. And one thing leads to another. I started, coming across the work of Dave Feldman and Cholesterol Code and Nadir Ali and, Malcolm Kendrick and those guys, and, realized what a fallacy the whole cholesterol paradigm is. And, so now I found myself in a very interesting place. Here I am, a cardiac surgeon, and I spent my whole career up to this point, telling people the reason that, they ended up on my table was because their cholesterol was high and, they were eating too much fat. And lo and behold, come to discover that there's a lot of flaws in that reasoning, and my own personal journey, and now the literally thousands of hours of articles and listening to podcasts and all the research I've done, has really shown me that that's not the case.
So tell us about your clinical experience. I mean, this is, first of all, the Palm Pilot Pro it was the first phones, man. They had a little stylet you could
know
take
what a
out
Palm Pilot is, guys. All right, what am I like?
So that was back when we used to dial the phone, right? We don't push the buttons. Anyways, Doc, clinically, I mean, I'm really intrigued by this because I know I had a little conversation with you in Boca saying, okay, what am I seeing in my patients who were having this bypass? The reason I bring this up, I had a patient this week, 47 years old, sought me out he drove a couple hours to see me, heart attack at a young age, Indian descent. So I'm like looking at his labs and all of his numbers. His cholesterol doesn't look bad. Everything looks pretty good. I'm like, what's your insulin level or your A1C? He's like, I don't know. No one checked it. Massive heart attack on a balloon pump. No one checked an insulin or an A1C on this guy, right? A1C, 6.3, insulin elevated. and this was the trend I'm seeing because I knew it was going to be. And so what were you seeing clinically that made you say, these patients who I'm doing surgery on? What could we have done to intervene to prevent them from being on my table?
Yeah, that is not an uncommon story, and 5-10 years ago, you would just kind of shrug your shoulders. You'd have these young guys that would come in and they weren't obese, and like you said, their cholesterol oftentimes didn't look bad, and they had just horrible coronary artery disease, and they're ending up on my table, massive heart attacks, the whole deal. And unfortunately, in medicine, we tend to just say, oh, well, they're an outlier, they're an exception. And it never really clicked. Once I started doing this, my eyes were open completely. And when you go back in the literature, there are some papers from the 1980s that they did test insulin levels on all the patients that came into the hospital with coronary artery disease, and 90% of them were insulin resistant. And somehow, between the 80s and the 90s, that we just stopped doing it. And to be honest, if I don't check the insulin level, it doesn't get checked. For the most part, people, mainstream medicine still doesn't even think to check it. We will check an A1C, and sometimes it looks okay, sometimes it doesn't. But like I said, unless I order it at this point, usually the insulin level has not been checked and will not get checked, which is something that I try to talk to my fellow cardiologists about, and trying to educate the rest of the medical team now, and then I have that discussion with the patient, which is the most important part, because obviously, if we're not educating them about it, then it's still not doing any good.
I'm a little interested here. I want to take a step back because there's something that you said that caught my interest, and you had mentioned that your wife kind of dragged you into gluten-free, and kind of you were supporting her and she was supporting you, and immediately I thought to myself, oh my God, my wife has been like a pillar for me. And I know Brian, he talks about his wife all the time being an amazing support for him. And I don't think any one of us probably could have done what we've done in our own lives to reverse our own health without our wives' support. So I'm just curious, what has she said as she's seen you evolve, as she's seen your diet change from 6 years ago to now? And has she kind of come along with you? And I want to know a little bit about, Dr. Philip Ovadia, not just the guy who's lost 100 pounds, not just the guy who's a board certified cardiothoracic surgeon, but just the guy,
Yeah, definitely. I mean, my wife is, truly the pillar of my life, and, the most supportive person I know with all of this. And she's certainly been on board with the journey, and she stays low carb as well. Doesn't quite do the hardcore carnivore that I do. She still, I would say, more as the keto camp. But you can't do this without support, and family is always important, and in whatever form that is, wives, husbands, siblings, parents. It's always easier when you're doing this with support, and it is difficult if the rest of your household isn't doing it or isn't supportive of it, at least. And I think I always try, and when I talk to patients, I always try and have their families there as well, so that it can be a team effort. It's like anything else, the patients that I see that are trying to quit smoking and their spouse is still smoking, that's almost doomed to failure. And then you got to have your motivation. And obviously for me, I want to be here for my wife. I want to be here for my kids. I want to be a role model for my kids. And, that's my main motivation. And I think that's very important.
Yeah, you hit it on the head. I think, Tro and I know, I learned from Tro this because he had more data than I did. Now I'm getting a lot of data, Tro. I'm coming after you. But, saying, look, family support and stress, lack of family support and increased stress levels are a massive indicator of success doing low carb. So if we have people with terrible support, or they're not ready, or we're gonna have someone on that has a new patient of mine that lost 110 pounds, not because of me, but because of what she did before she met me. But she has a mindset. She was all in. It wasn't about, oh my gosh, I don't want to give up this. She was, I've got to make a change, and I'm doing this. And those are the people that we see are very successful. So, Doc, are you still? We had some internet problems. Are you still with us?
Hopefully he's still with us.
Okay, we'll take a break. Well, Jack, cut this out for a minute. Maybe we can pause it. So, Doc, we had a little technical stuff going on. My question is this. Now, just stepping back, we understand the importance of support and having the right mindset. In your case, have you seen people with normal insulin level, normal sugar, and getting a bypass surgery?
Now that I know to look for it, I have yet to see a patient like that.
That's what I've been curious. I've been curious about that, because I want to make sure we're saying the right thing, and you're the one doing these surgeries and seeing it. So that's been my experience also. When I heard Ivor Cummins talking about Dr. Kraft, I went back and looked at my practice. Every single person who had a bypass or multiple stents had elevated insulin levels. Above 5 is what I would call the cutoff for normal insulin levels. So that's what I'm curious about to say, because I think I would love to hear your opinion as far as pathophysiology. Then I'll let Tro jump in here. But what's causing the heart disease epidemic that we're seeing here? Is it high LDL cholesterol? Is it oxidized LDL cholesterol? Is it the damage and LDL's there to fix it? I hear a lot of different opinions on that. What's your opinion on how do we as Americans reverse this #1 killer that we have of cardiovascular disease?
Well, I think, I think we need to start focusing on metabolic health. We talk a lot about weight loss, and that's often a part of it. But I really try and refocus the discussion with patients towards metabolic health. And as I said, you can go back into the late 70s and the early 80s, and there are the large studies looking at patients, with heart disease and who came for bypass surgery. And when you check it, they're nearly universally insulin resistant. There's probably an occasional patient that maybe it's smoking, or maybe there's some other factor. There was some rare vasculitis and stuff like that can, probably cause some coronary artery disease. But I think you have to, at this point, assume that it's insulin resistance, but you also have to look for it. And as we've been discussing, we don't look for it nearly enough. But when you look for it, it's almost always there.
I have to agree. It's like something we're finding again and again, that insulin resistance rears its head in multiple forms. I want to come back. So here you are, the man who's, lost 100 pounds and did it in a way that most of his colleagues probably wouldn't agree with. And now you may have noticed things like, diet-induced hyperlipidemia. Certainly, we're very well familiar with the hyperlipidemia of metabolic syndrome, the high cholesterol of metabolic syndrome. But maybe, as you've lost weight, you've noticed that your own cholesterol has gone up. Certainly mine has gone up and down. Do you think that I'd like to ask a very specific question. Do you think that these are two distinct entities, the hyperlipidemia of metabolic syndrome, the dyslipidemia of metabolic syndrome, and maybe a diet-induced increase in cholesterol, specifically with intermittent fasting and low carb? Do you think those hyperlipidemias are the same? You're the heart guy, so I'm hoping that you could tackle this one. And if you can, but I'm curious, what your thoughts are about that.
So, personally, I think there's definitely a difference there. And, I can tell you my personal, kind of experience is my LDL has gone up significantly. It tends to hang between 250 and 300, kind of depending on how much fasting I'm doing and what I'm eating. But with that, my triglycerides are half of what they have been. My HDL is double what it was. And I think that's the important distinction. I think the hyperlipidemia that we see with metabolic syndrome, you know, the HDL is low and the triglycerides and the LDL are both high. With, you know, low carb, fasting, and honestly, I'm not sure, you know, which of the aspects it is. I think fasting has a lot to do with it, and I think where you are in your weight loss journey has a lot to do with it. I think, you know, the more your body is you know, burning fat and using that for energy and shuttling that all around, that's often reflected in the lab work. But you know, again, I think you know, my personal experience, the experience of the community out there, is that, you know, almost everyone, their HDL improves, it goes up, their triglycerides go down, and the LDL, you know, it seems to be a mix. Some people stays the same, some people it goes down, some people it goes up, and that doesn't seem to correlate at all with developing any sort of cardiac problems. I, of course, you know, had a bunch of my cardiology buddies telling me I was headed towards a heart attack. So I did go and get a CAC scan. I got a 0. And so, you know, that tells me, and when you look at the data, that more than any blood predictor, you know, tells someone that they're at low risk of a cardiac event. And nothing tells us we're at 0 risk, but yeah, it's pretty low risk.
I'm curious, did your pattern, so again, you know, there's a lot of focus on the hyperlipidemia of metabolic syndrome, and that carries a very distinct pattern of cholesterol. You know, you mentioned the relationship with triglycerides and HDL, but do you know if your pattern also changed from a, you know, the kind of the one type B pattern associated with metabolic syndrome? Did that also change, and do you think it matters?
So I never checked it prior to starting this. The time, I've only checked it once since, and I am pattern A, which is the lower risk pattern. So I don't know if it changed, and I also don't know that it matters. You know, I've kind of, as I've gone through all this, I've become less and less, you know, even concerned about the lipids, honestly. You know, I tend to check them, you know, once or twice a year, you know, just to sort of keep an eye on it. But in reality, I don't think it matters a whole lot. I think if you're keeping your insulin level low, you know, it probably not very relevant, you know, what your cholesterol numbers are. And so I think, you know, when patients and, you know, ask me, you know, what's the most important blood test with all this, I tell them fasting insulin level.
I agree. I think it's what neighborhood that LDL's in. Is like with a kid, is this going to be a good kid or a bad kid? It depends where they grow up and who's training them, who's educating them, right? So I think that's a big, you have to look at the neighborhood, and that's what we're seeing clinically also. I've been seeing the same exact thing. It always gives me trepidation though when I see an LDL go to 300 or 260. I was like, gosh darn it, here's what the guidelines say, here's what everyone says, here's what, you know, and educate the patient and saying, okay, look, we don't know the data. I mean, I think right now we're still at the infancy. We have to wait for, and Dave Feldman's doing some good work. Again, because we're seeing, I see, as a matter of fact, a young athlete came in, I mean, young to me, I guess he's 40 years old, and you know, triathlete, very fit, LDL's high. They put him on a statin drug. I said, I'd get a coronary calcium, see where you're at. 0. I just talked to him last night. 0. Your score's 0. Go back, take this to your doctor, see what they say, because they're just looking at the number. This guy that has 6-pack abs, he's very fit, insulin level low, he has no risk factors other than a high LDL cholesterol. So it's kind of a tough one when you see that. And we see that a lot. Tro and I see that a lot in young athletes coming in. I've seen triathletes and their LDLs through the roof because they're burning off all their fuel and they're pumping more fat into their system, right? So it's an intriguing thing. And so we've, like Tro, I'm like, Tro, what do I do with this guy? We put him on, you know, liberalize his carbs a little bit, cut back on the exercise. Lo and behold, LDL drops significantly. And Tro, you probably have a case study on that. I know you have some pretty amazing work you've done.
Yeah, we're working. You know, I don't want to jump the gun, but we've had some preliminary talks with David Feldman. So I know Ovadia, Dr. Ovadia, you have a ton of good patient data to probably support this. And I know, Brian, you do as well. So maybe we can pool all our data together. The idea would be to show that it's not the saturated fat. When you have a diet-induced hyperlipidemia, when you've reversed metabolic syndrome with low carb or intermittent fasting, right? It's not the saturated fat that's driving that high cholesterol, right? Which is the current thinking. Like if you go to a cardiologist now, he's like, oh, you got to lower your saturated fat. And that's not the case. If you add just a little bit of carbohydrate, the LDL goes down, right? Just a tiny bit, if you wanted to. I mean, some people add a little bit of carbohydrate and they feel completely terrible. And, you know, but if you're an athlete with six-pack abs, certainly you probably could tolerate a little bit of carbohydrates without jacking up your insulin level. So, yeah, we have some data on that. You know,
yeah, and I think the fact that we're even debating this, you know, says a lot. You know, when you check an insulin level and it's high, I can't imagine there's any doctor out there that's going to say, well, that's all right. You know, it's okay to have a high insulin level.
Oh, there are.
The LDL.
There are, and the problem is they're not even looking.
They're not even looking
to see.
Well, that's the thing. They're not even looking. But,
Yeah.
you know, if you look and someone comes back with an insulin level of 40 or 50 or 60, you know, you know, that I think is not debatable that that's a bad situation. You know, I just can't, you know, the LDL, we go back and forth and there are all these, you know, there are different camps and, you know, you go back and you look at the studies on it and, you know, the data is very mixed. I guess I haven't done the literature search yet for this, but I can't imagine you can find a study out there on patients with a high insulin level that doesn't correlate to bad outcomes.
Yeah, I think the most stunning one.
That's the modern population. We know that it's bad.
Exactly right, and
right,
the thing,
exactly.
And the thing that's stunning about it, and this is
we
the
have
thing.
plenty of. I was just going to say we have plenty of studies that you know, that look at people with high LDL levels that don't correlate to bad outcomes. So,
Yep. And
you know,
specifically high
when you
LDL,
really look
low
at it
triglycerides.
objectively, that's a lot more questionable than a high insulin level. That's the way I've come to think about it.
Exactly, and that's the fight we have to pick up because, you know, Ibra Cummins sent me a graph and I looked and I was stunned. It was the country of Colombia where I don't know if you guys saw this study, but they said, look, let's look at people who had a heart attack and didn't, and we're going to compare their labs. LDL, no difference. Total cholesterol, no difference. Hypertension, doubled the risk of heart attack. High insulin level, almost 700% increased risk of cardiovascular disease. And I was like, holy cow, if this is true, how come no one's even looking at that? How come no one's even talking about it? And I show my patients and I said, well, the difference is I have a drug for the LDL that I can give you to lower it down to make you feel better, but it did make a difference in that study at least. Lowering your insulin, guess what? You have to do lifestyle. You have to do lifestyle. And that's going to take a lot more time, but it's a lot faster for me to throw a statin on you rather than saying, okay, let's look at the underlying cause, the root cause, as Ibra would say. So I think that's what's exciting about the research and what we're seeing clinically. We see it. I mean, there's no way. I was shocked when I went back to my practice and everyone had elevated insulin that had cardiovascular disease. It was stunning to me. But we should have known that because we know diabetes is an independent risk factor. It's assumed that you have coronary disease if you have diabetes. That's why we crank you on statins trying to knock down that LDL as much as possible.
Can I bring up something because I think this is going to be important to get Dr. Ovadia's input, and it echoes what you just said, Brian. Statins cause hyperglycemia and they worsen insulin resistance. So I know this is a tough subject because statins have in some studies been shown to reduce mortality. There's criticisms of those studies. It's certainly associated with a decrease in cardiovascular mortality in some, some studies. But it certainly worsens the major problem that we believe is driving metabolic health and heart disease. So what do you say? I know this is a tough subject, and if you want to, but I'm curious what your thoughts are about statins because we know what it does. It worsens diabetes, it worsens blood sugar, worsens insulin resistance. So, but it does lower the number. So what do we do?
Exactly.
What do we do?
So, this is always a tricky situation. So, especially for me, because, a patient who has had coronary artery bypass surgery, who has coronary artery disease, the guidelines say they should be on a statin. And actually, it's one of the quality measures that I get measured on. So if I send a patient home after heart surgery without a statin medication, it's a ding on the record. With certain limited exceptions, you basically have to document that they didn't tolerate it. When you look at the data on statins, what I usually talk to patients about is the only data that I think is convincing is none of it's really convincing to me, but the strongest data for statins is in what we call secondary prevention. So patients who have had an MI, had bypass surgery, have known coronary artery disease, and even that data is pretty weak. We're talking about risk reductions of 1 to 2%. In the absolute risk reductions, and those studies largely ignored the long-term effects of statins. They looked for acute side effects, but they didn't look at the long-term side effects. Like you said, we know it increases the risk of diabetes. We have very good data that suggests it increases the risk of Alzheimer's disease. There are the liver issues and the muscle issues. For primary prevention, I personally consider statins to be not indicated for primary prevention. But again, it's a tricky discussion to have in our current environment. It certainly goes against the common thinking. And for right now, I don't necessarily see the patients that I see as part of my cardiothoracic surgery practice, obviously are all in the secondary prevention bucket. And for now, I tell them, the statin is indicated, but I do talk to them about these issues. And, I do mention that it can have side effects, to be on the lookout for side effects. And I tell them that the benefit from the statin is relatively low compared to, if we can fix the insulin resistance. So if anyone's having any side effects of statins, I have a very low threshold for having them stop them.
Well, so I want to talk about that, because the side effects of statins, particularly the hyperglycemia and the insulin resistance, are ubiquitous. Right there, like it's literally, if you look at every stroke trial, every MI trial, every trial with the use of this, hyperglycemia is worsened, right? Particularly with the high dose statins, which is what's being recommended. So I feel like it's like, look, if we know fat is transported by cholesterol for fuel, and we're asking our patients to lower their insulin and utilize their own fat, right? And then we're giving them a drug that's lowering that vehicle, right? Of course it's going to cause hyperglycemia, right? Of course, like it makes sense. So I have a hard time reconciling it. I don't know. I just want to hear both of you guys.
Of course, everyone, we're not giving you medical advice. We're having a discussion among docs. We're debating this and discussing it, because Ben Bickman, we had a great discussion with him on this podcast. So definitely go back and listen to it if you haven't, because I said, well, what about this issue with the high sugar? Well, he says, what you're doing is blocking the rate determining step of converting that extra sugar over to LDL cholesterol, which is the small, dense, bad one. So he says, well, of course, when you block that step, it's going to back up the raw materials, right? So your sugar goes higher in your bloodstream. So can we make the argument? I think we would all agree, saying, okay, if you're going to put someone on a statin drug, you darn well better cut their carbohydrate intake. Because you're going to cause hyperglycemia. It's just what it is. It's just doing its job, and that's what it's doing. It's not that the statin is causing hyperglycemia. It's just saying it can't take care of that problem, because your body's saying, I've got to get this sugar out of the bloodstream because it's toxic and cannot stay there. So what does it do? It converts it over to cholesterol. It does. Those carbons are the same, according to Dr. Bickman, who I trust with my life, really. So you go, okay, should we be cutting the sugar intake? No one talks about that component of it. Because if I put you on a low carb diet and I put you on a statin, will your sugars go up? Nope, they will not. They won't, even on a statin drug. So that's what I'm saying. If we have to do lifestyle, nonetheless, you're going to have to do that. You can't just throw someone on a statin and say you're going to be fine, because you're, again, like you're talking about, you're raising the insulin level, you're raising the sugar level, you're causing more problems if you don't address the underlying cause that we're talking about anyways, if that makes sense.
Well, and I think that's a very good point, addressing the underlying cause. One of the parts of this discussion is the patient needs to be willing to address the underlying cause. So, if you have heart disease and you're not going to address the insulin resistance with lifestyle changes, low carb, then yeah, stay on your statin. I still don't think they're great drugs. And I think when you really educate the patients and explain to them, you can have a lifetime of taking these drugs, or you can change the way you eat and not need the drugs. Most patients, once they understand it, and once they have the proper support to enact it, would rather change their diet. There are some that don't, and our role as physicians is certainly not to force anything on the patients. It's not to force medication on the patients. It's not to force lifestyle on the patients. Our role as physicians is to educate the patients and support them, and give them the options. And I think the biggest problem, the biggest mistake we've made in medicine is that we don't even give the patient the option anymore. We just say, take your statin, and that's the only thing you can do to lower your cholesterol. We don't even have the discussion with the patient, for the most part, that there is an option of lifestyle changes.
I want to talk about this because you're hitting the nail on the head. Doctors, and Brian, I know you're passionate about this. Doctors don't have the time. They're burnt out. They don't have the time. And in the current model that exists, which is, get paid pennies for our time, we are forced to rush patients. We are forced to not be able to explore. Why is the LDL going up or down? What does it mean? Even the insulin level, like you talked about, right? You talked about the importance of insulin. Some docs, see an A1C of 6.3 and they say, that's great. I don't need to put you on a medication, but the insulin level is 50, right? And they don't know how to interpret that. What's going on? Hey, the pancreas is redlining. Some docs see an A1C of 6.4 and see an insulin level of 5. And they don't know what that means. Hey, maybe the pancreas is about to stop. And it's about to, and that glucose is about to rise because the pancreas is burning out, right? And so the problem with LDL and insulin, I think the problem comes down to docs don't know what it means. And they've been paid to just see patients quickly, and they've been paid to not focus on the patients and discuss with patients and learn.
Well, Tro, and
how do you talk about that?
That's huge. I'm going to cut you off, Tro, because I agree with you. And I think the other thing is, look, we're trained to look at numbers, not patients. We're looking at numbers. Your LDL is above 130, statin drug. Your sugars are this way, statin drug, or whatever we're getting, insulin. And it makes me, as a matter of fact, I'll tell you, just yesterday, I saw a kid, 18 years old, type 1 diabetic, who's now type 1 and type 2 because he's insulin resistant. They've been cranking his insulin, cranking it up. He's on huge doses, just like Andrew, who we had on. And saying, okay, your A1C is at 7, you're at goal. It's like, holy cow, man, this kid's eating terrible food, has no. So I educate the kid a little bit. Now his sugars are dropping like crazy. We're taking him off insulin already, like in a couple of days, right? So it's so frustrating because they're saying, oh, your sugars look better because we're giving you a ton of insulin. So let's just keep cranking it up until we get your sugars better, but not ever stop putting the sugar in the system in the first place. It's insanity that this poor type 1 is now type 1 and type 2, really, right? So he's insulin resistant, plus he can't make his own insulin. So they just keep cranking up the numbers till they get the number they want. It's just insane.
Yeah, I certainly agree with that, and I think it's a symptom of a larger problem. And one of the side effects of having your eyes opened, on the weight loss and the metabolic health side of thing is realize how much we've lost control of medicine as doctors. And I think one of the other things I've become passionate about, and I've started to see how I can help is, we got to get control of medicine back. We got to get control back from the insurance companies. We got to get control back from politicians. We're 45 minutes into this, and thankfully we haven't mentioned COVID yet. But one of the things that I think we've all started to see with everything that's been going around in COVID is that politicians are deciding how medicine should be practiced, and at some point as doctors, we got to put our our feet down collectively. We're all busy, and we've all, run our whole lives with, our nose down to the grindstone and just doing what we need to do to, kind of get through the day and keep our patients alive. And while we've been doing that, the insurance companies and the hospital administrators and the politicians have just taken all of the control of medicine away from us. And that's something we've got to start fighting back against as well.
Yeah, we've absolutely lost our minds. We've lost our minds when we can't have open debate. This hydroxychloroquine debate it at least. Don't block this stuff. Discuss it and go, these guys nuts or not? Here's what our opinion is. Here's what your opinion. This is how Tro and I have thought from day one of what we're doing, because at first everyone said we were nuts, like crazy. How can you guys talk about this stuff and say, look, who's dying of COVID? The metabolically sick. There's no doubt about that. And it's frustrating when our government or whoever's in charge doesn't say, guys, we got to change our lifestyle. We got to attack this and prevent it, because people who are metabolically healthy, they don't have to live in fear as much as the people who are metabolically sick. And we can change that, as we know through Rob Sivas's data, in 3 or 4 days. You could reverse fatty liver disease. That's insane to me. And we're spending billions of dollars with pharma trying to figure out a drug that will do that. Why? Because lifestyle, because we don't want to say, okay, stop eating your whatever and start exercising, watch your stress level, get enough sleep, take some vitamin D, get out in the sun, and we could reduce your risk significantly. And it's frustrating no one's talking about that. I mean, very few people are talking about that.
Yeah, it's incredibly frustrating. And, like I said, it's, I guess I've become a little crazy like you two. And, I'm starting my own practice that's going to focus on metabolic health and focus on cardiac issues. And I've, made a number of changes in the way that I, practice medicine and sort of the business side of it, so that I can have more control. Looking for ways to get involved on sort of the larger levels, so that, we can come together as a physician community and start to take back control of medicine, because we're the only ones that are going to be able to fix this. The politicians have had 50 years and they've only made it worse and worse. And, the doctors are the only ones that are going to get ourselves out of this.
I think the number one thing is to take the physician back and make them the community educator that we once were, right? That is the key first step. Is we have to come back to being educators. We have to be able to reach out to people, reach out to gym owners, reach out to restaurant owners, reach out to people. We have to be able to be rewarded for our time to educate. So the first thing is make us educators again. Right? And then, but before you become an educator, you got to be inspired to be curious. And you fit every one of those check marks. You're inspired to be curious, right? Because you've seen things that you can't unsee. And then now we have to make it so you can financially, it's viable that you can be an educator.
We'll put it
and then
this
we
way.
can be, and then
Yeah.
after we're an educator, you could be a doctor too. You know,
One
so
is
I think that's the key here. I hope.
The crazy thing is none of these guys have any business sense, Tro. That's the problem. That's all of our problems, right? The problem is this. Dr. Ovadia can make way more money doing a CT surgery on someone than preventing it. Nadir Ali can make a lot more money doing interventional cardiology than preventing them from getting to his table, right? Christian Assad, all these people that we see, Gary Fetke, he could amputate feet all day and make a ton of money, but he wanted to help his patients and prevent it. Jason Fung saw all these people on dialysis all had metabolic disease. And he said, well, why don't we fix it before they come to me, right? So all these guys hurt their own income, really, and us too, Tro, because our patients are healthier. We know, well, doing direct primary care is a bit different model, right? Because I tease my patients, but it's true. I said, the longer you live and the healthier you are, the better I do. Why? Because I don't have to see you all the time anymore, because I'm upfront investing in you. If I get you on the right path, I don't have to see you every week. If I don't, and you start getting the diabetes complications, that's what's bleeding the system dry. So if we can prevent these things, guess what? You live longer, I make more money. You're healthier, I make more money, right? And it's not about the money, but it's about saying, hey, look, I want you to have the quality of life to be able to, I'm invested in your health. I'm invested in you staying healthy. Before, when I was in the insurance model, the more diagnosis codes you get cancer, I get paid more. You get diabetes, I get paid more. There's a problem with that system where I get paid more by allowing you to get sick than reversing diabetes or preventing it. It's insane.
What say you, Dr. Ovadia?
You know, what I say is, one of my new goals is to be one of the worst businessmen in history, because I'm truly looking to put myself out of business. As I mentioned, I'm starting a new practice that's going to focus on metabolic health and cardiac health. And, you know, honestly, if we get to a point that there are no more patients for me to operate on, that would be a great day. And I'll be a happy man, because that will have meant we will have helped so many people and truly change the course of this country. You know, because what's really insane about the whole situation is, you know, even when you look at it on the you know, on the larger, you know, political, you know, landscape of all this, you know, we're bankrupting our country taking care of these people that are, you know, with diabetes and with heart disease. You know, they're the two biggest killers, and honestly, they dwarf any other problem we have. You know, the number of people that are, you know, are going to die from COVID this year still won't even come anywhere close to the number of people that are going to die because of heart disease and because of complications of diabetes. And if we could fix one problem, we're going to fix almost all the problems. Because again, you know, as we mentioned before, you know, when you look at insulin resistance, it's at the root of almost every chronic condition we're dealing with. It related to a number of cancers. It's hypertension, it's diabetes, it's heart disease, it's stroke. It's all of our biggest killers and all of the things that are making, you know, people go out on disability and decreasing health span and decreasing lifespan. And we gotta refocus the discussion.
So Doc, how do people find you? How do they get in touch with your clinic? Because it's incredible. Where are you? What kind of people are you taking? You know, are you taking insurance? What are you doing over there? So, because we really think it's important, the preventive part of it.
So in the process of launching Ovadia Heart Health, it will be at ovadiahearthealth.com. Probably around the time this podcast comes out, it should be up and running. In the meantime, you can find me on social media, on Twitter at iFixHearts, all one word. Is where I'm active, and the practice is going to be exclusively telehealth, online only, and you know, between a mix of it's going to be a mix of health coaching and true telehealth. You know, the states that I'm licensed in and can do the telehealth, it can be a full scale medical care. Patients that are from elsewhere that I can't provide, you know, the true full-scale medical, you know, I'm still available for coaching around metabolic health, and I'm open to working with their local doctors. And the good news is we're building a nice network of, you know, kind of low-carb friendly doctors, the different organizations, Low Carb USA and Sean Baker over at MeatRx has a growing list. And there are a couple others that, you know, it's becoming easier and easier to direct patients to the physicians that are open to this type of care. Obviously, what both Tro and Brian, what both of you guys are doing with your clinics, and I know you're working on getting licensed in a number of different states to be able to available to more and more patients as well. And we just got to keep building that network and coming together as a team in all of this.
Yeah, absolutely. I can't like, you're preaching to the choir right now. One, we have to make it financially viable so we can remain curious and remain invested in our patients. Two, we have to make it so that patients get excellence, which I know, you know, and then three, we have to talk with each other. So when they're done seeing me in New York, or when somebody calls me from Florida, I can say, no, go to Ovadia. He's going to take care of you, right? You don't have to fly in. I literally had some people fly in from South Carolina, Georgia, you know, and during COVID, because they needed somebody to establish care. And if we can have somebody, you know, and we just referred a patient, you know, who was a health coaching client of ours. We referred her to Kristen Bear. Referred her because, you know, we know that she'll be in better hands. And so I think creating a network of, you know, you should be able to see somebody, take them off their drugs, coach them with lifestyle, manage their diet. And when you're done with them and they move to New York, they should be able to come see me and pick up where they left off, just as if you wrote them a statin or a metformin and I'm giving them a refill, right? So we need to all talk the same language and we need to support each other, because I think that's the future, creating a network of like-minded doctors across the United States.
Yeah,
So,
and the funny thing is, obviously, as docs are the worst business people, and two friends of mine are business experts, and they've made millions of dollars, and they laugh. They go, "Brian, you're crazy. You're calling it low carb MD. You're totally pigeonholing yourself. You're limiting yourself." I'm like, first of all, I want to limit it to people who care about this, that are willing to make lifestyle changes. Second of all, 88% of Americans are metabolically sick. If I focus on metabolic health, I've eliminated 12%, but I really haven't, because those 12% want to stay healthy too. So doing what they're doing now, they're going to be part of the 88. So then it's going to be 96% of Americans are metabolically sick. Then the next big disease comes through and wipes out half our population. So at some point we have to say, okay, let's prevent this and not live in fear. I think being proactive, I have patients right now that feel so much better than they did a month ago, because they know they're metabolically healthier. They're seeing their insulin levels drop. They're seeing that they're getting they're improving their odds of survival should they get COVID, right? So I think these are all really important issues that we really need to look at. We're looking at the whole organism. Our job is to look at that patient in front of us and say, what's the most likely thing to kill you, right? If you're smoking every day, okay, you got to look at that. Or you're eating cookies every day, we have to look at that, and say, can we taper it down? Can we stop? How do we get you healthier? So that's what's exciting about what we're looking at. We see the problem, and Ben Bickman's great book just came out, Why We Get Sick. I would recommend everyone read that. I haven't read the whole thing yet. I'm working on it, and there's so many great people out there, and really the reality is we're all kind of saying the same thing, maybe in a different way. Putting on muscle mass, some people are focusing on that, cutting carbohydrates, getting enough sleep, don't be stressed out all the time, and that's what we have to look at, and we have to say, my doctor is only spending 6 minutes with me. Can they educate me? Can they do their job? They can't, unless we do it in a group forum. And I had considered that, and I will do that. As a matter of fact, Tro, I'm challenging now. I'm meeting with some patients who are doing medical weight loss, and we're meeting Thursday afternoon, and we're going to go for a walk and talk about life and talk about what's important and talk about our health, right? That's critical. We're building a community, and that's what our goal is. That's what we have to do, is have people that support us and they're on the same path. So as we start doing these kind of things, Tro, what you're doing with the community forums and helping people, that's what we have to do. We have to reach as many people as we can, as time effectively as we can. So that's what's exciting about the way medicine is changing. This podcast, Tro, I mean, how many people have we touched? I mean, I'm blown away. I'm blown away when I talk to people and they go, yeah, I lost 110 pounds listening to your podcast. I lost 50 pounds. I came up, my eczema's gone. And it's incredible to us to hear that, saying, wow, these are people we never met before. And they just said, let me try this and see what happens. One of my ladies, this is fun. I'm going to have her on the podcast, Tro. She did 6 months of the DASH diet. In 6 months, she lost 6 pounds. Switches over to low carb keto, more carnivore based. She's lost 110 pounds, resolved tons of health problems. She's like, what's my opinion on the world health with all these people ranking the diets, because they have no idea what they're talking about and they call themselves experts. She goes, let me tell you my testimony. And you listen to her story, you think, holy cow. I mean, and she drove a far way to see me. She's already metabolically healthier now. And she says, I'm just sick of my doctor telling me I'm killing myself by losing 110 pounds, coming off all my meds, and I'm killing myself every time. And I have to get a lecture about I have to be vegan, right? It's frustrating, but seeing the numbers and hearing the stories, and the power is, as we get more and more docs understanding this, we're going to save a lot of lives, and we are going to have numbers and say, okay, you want to look at our numbers? Here you go. Let's see your numbers.
I think the ideal, and Dr. Ovadia, I hope you agree with this, is that soon, we're all kind of setting up individual camps, Kristen and Brian in California, you in Florida, Andy Fung in North Carolina. But soon, I hope we all start to move in step together. Doesn't have to be, I'm not, I don't want to be involved in your stuff in Florida. You don't want to be involved in my stuff in New York, but maybe we can all work together in terms of centralized, presence and kind of group protocols, sharing data, so that we can publish kind of what we find, and that's a real big passion of mine. And I think it's probably financially makes sense, but I think from a ethical perspective and really changing the paradigm, I think that's what's needed. So I'm so excited to see you get set up in Florida. I know I'm going to be referring many patients to you because, my patients need it. my patients need it. And I know that, now when people come see me from Georgia or call our office saying, we're in Georgia, we're in Florida, we're going to fly up to see you, I could say, no, we have a great doctor, Philip Ovadia in Florida. And we kind of have a similar philosophy. We won't practice the same, but, we have similar philosophies. And if you come see me, fine, great, but he can pick up right where you left off, right where we left off. If you move to Florida, you can go to see him. He's the guy, right? And you don't even have to go to his office. He'll see you remotely, right?
And
I think that's a beautiful thing.
Then that kid we're mentoring, Rob Sivas, we're trying to teach him this stuff. And no, I'm just kidding. He's brilliant. He's a brilliant mind. And you're right next to him. You guys team up. It's unbelievable what you can accomplish. I'm so blessed to have Ariel Ortiz really close to me. He's brilliant. He's a friend of Rob Sivas. He's doing it. Troy, you need to find someone like that, right? So together we put our minds together and say, how do we help the patient? Brian, you do the pre-op stuff. Let me do op when necessary. We're not at war with each other. When we start realizing that, we're out to help the patient. And, it's amazing because what's going to happen, mark my words, and we'll talk about this later. The orthopedic surgeons are going to be calling us left and right now. Why? Because we can help their patients be cleared for surgery. They have a ton of patients that are so metabolically sick, they can't do surgery on them. So give them to me for 6 weeks and see what I could do with them. We'll send them back to you. And then you do your surgery. And guess what? A lot of them won't need surgery because they're going to do better. They're metabolically going to be healthier. And that's crazy, but that's what happens.
Exactly. And I respect so much what you two have been doing. And again, you guys have certainly, laid the groundwork. And I think, we need to focus, we need to refocus medicine towards working together. As you said, Brian, 88% of Americans are metabolically unhealthy. So there's plenty of people to go around. There's no competition here. We can never have enough low carb doctors to tackle the 200 plus million people who are out there that need this service. And the more we can work together and the more we can spread the word. The podcast is unbelievable. The conferences, I've now been to 2 low carb conferences, and honestly, they're the best medical conferences I've been to in my life. And what I really love about them is they're not limited to medicine. There are patients there, and there are guys like Dave Feldman there and Ivor Cummins, and we can learn from engineers, and we can learn from computer scientists, and we can learn from each other, most importantly. And learn from our patients. And I think that's what we all have to work on as a community.
So true, man. So true.
Hopefully in 5-10 years, we'll be all working together, kind of having gyms, remote monitoring, mental health counseling, cardiovascular counseling, metabolic counseling, all under one roof. Hopefully that dream can someday be realized. So I thank you so much for coming on, Dr. Ovadia. Brian, it's always a pleasure. Brian, I did find Ariel Ortiz. You.
I'm no Ariel Ortiz, man. I'll tell you that, man. Yeah. This guy is unbelievable.
Philip Ovadia.
Yeah, that's what I mean. All of us have. We all have found each other. And I think when we start all seeing our clinical success and saying, okay, and, I'll, just honestly, because I know this is a thing that comes up a lot. Again, we've been criticized on the podcast. We've taken $0 from any outside interest, zero, not $1. If Philip comes out with a book tomorrow and sells 1 million copies, we don't get a dime from that, right? So having integrity is really important. And I think all of us, I know what Philip had to make way more than what we're making, Tro, to step down and start doing this kind of medicine. It shows a passion, right? So we all have passion. We all care about it. I took a massive pay cut, maybe not massive, but took a pretty good pay cut to do what I'm doing now. But guess what? Every day I come home, my wife's like, you're loving it. You're just happy. And you're like, because I tell her stories, I'm telling her like what we're seeing. And it's so fun. That's what, again, my topic that I'm talking about at Low Carb San Diego is physician burnout. It's a burnout to see your patients getting sicker and keep throwing pills at them and you can't help them and you're helpless. Like Dr. Unwin talks about, like all these guys that are our mentors, they experience it and they said, okay, I can't keep doing this. I didn't come in. Female physician suicides through the roof right now, right? Because they're not helping people and they've sacrificed their own lives, not having kids, not having relationships and all that. That's a huge sacrifice, what we've gone through, all of us have gone through. to realize you're not helping people and that you're just there to make a buck is devastating for people, because it's never been, most doctors, you say, I've never seen someone on their mission statement, you know, when they apply to med school, say, I want to make a lot of money, that's why I'm a doctor. We went into it for financial security for sure, but we're not going to do it for free. But the point is, you know, most of them, the problem is they realize they become a tool of the system, and we're pawns in the game. And I think COVID has brought that to a forefront, because a lot of these great docs who've been on the front lines, they don't have personal protection gear, and they're like, okay, go out there, you're a hero, go save us, and I'm going to sit in my office real comfortable like the general, and there's air conditioned office while other people are on the front lines. So I think that's really a lot of doctors stepping back saying, what the heck am I doing here in this huge system? I need to change. And I think out of this is going to, and plus a lot of people are looking and saying, I want to be healthier. No one's ever told me about diet or exercise. Why are these guys talking about this on the podcast? So I think there's a lot of people, there's a big groundswell happening with direct primary care, and with people saying, look, my health is worth, there's nothing more important than your health. As a matter of fact, I know multimillionaires that are so sick they can't even enjoy their money. It's like, well, what good is it at this point, right? Because you drank and smoked and did all the bad stuff you did your whole life. Now you can't walk because you have peripheral neuropathy from diabetes. It doesn't care what your financial status is. And when you're on dialysis, you know, you're going there 3 days a week. It's a nightmare. It really is. No matter how much money you have, it's a nightmare. So we're saying, look, invest in your health. Go see Dr. Ovadia. Go see Tro. You know, and none of us need the money bad enough where we're going to beg to have people come. What we're going to do is do the right thing, and the people come. And that's what we're, you know, it's tragic to me that I had people driving from Northern California to see me, from other states to see me or to see Tro. And you know, Andy Fungus experiences, people are up driving 5 or 6 hours to see him. Why? Because they want help, and they're desperate, and their doctor's not helping them, or they're saying they're doing the wrong thing without knowing the data. So I think it's so exciting what this path we're on, guys, and you know, Dr.
I want to
credibility. Really, you give us credibility because you're a cardiothoracic surgeon who understands this.
I want to hear some. You know, can you give us, Dr. Ovadia, some your 3 or 4 tips for heart health? So my wife, you know, she's always telling me, she's always asking me, are you sure this is healthy? So, you know, I'm going to say that this is non-medical advice, but can you give me some parting, you know, 3 tips for my heart health, you know? And
supplements you would recommend to protect my heart.
So I think, you know, in the end, like I said, it all comes down to metabolic health. I don't think we can separate heart health from metabolic health. And I think, you know, metabolic health is you know, for most people going to be low carb in some form, and that can be, you know, just kind of low carb, it can be keto, it could be carnivore. I think there's a large range there, but if you're not focused on the right thing, you're not going to get the right outcome. So we got to focus it on metabolic health. Honestly, there are no supplements I recommend, and no supplements that I take. You know, I always say steak is my supplement. And I kind of agree with Sean Baker there. You know, I think when you have your diet right, you probably, you know, except in rare circumstances, don't need supplements. Maybe if you live up north like I used to, you know, maybe some vitamin D during the winter. But you know, again, if you can get out in the sun and get your vitamin D naturally, and you can get these things from your food and from your environment, that's always going to be better. And tip number 3 is you know, kind of related, but I would say you know, sleep and stress, you know, are 2 things you got to manage correctly as well. And again, that just plays into the metabolic health issue, but those are the things I talk to the patients about, and I talk to my friends and family about.
Good. I'm going to say to my wife that this, you know, sounds like I must be doing the right thing, that this hotshot, you know, cardiothoracic surgeon agrees with me, because so I'm going to use that. I'm going to tell her that, you know, somebody much smarter than me is saying the same thing.
Amen, man. We can end on that. And I think that's great advice, is, hey, live a healthy lifestyle. It's going to do way more than just
Dr. Ovadia is like, I don't want to get in between you guys.
Yeah.
Yeah.
I was just going to say that going into cardiac surgery didn't make me smarter than you guys, and in a lot of ways it may I think you guys are the smart ones. I'm just here plugging along, you know, doing my thing. But as I said, you guys have both inspired me so much, and I've learned so much from both of you. And first and foremost, it's not about being smart. It's about being willing to learn. I think that's what we all have to keep in mind.
Man, those are words of wisdom for sure. Yeah, being able to learn. We're learning from all you guys, and it's so reassuring to have you on. Greatly appreciate it, and we are so excited about you getting up and running. And hey, anyone in Florida or wherever, reach out to him. Or find him. He can help you. We know, and you hear this conversation. What we're talking about, it's a lot of controversial stuff. It's a lot of stuff that is uncomfortable for us to even talk about. But I think it's critical that we look at the data and then reassess. We look at clinical outcomes and reassess, and we can't just be stuck in something that we learned 30 years ago that everyone said was true, right? And so many of those things have been debunked, and all we could do is learn, and we have experts from around the world. We're not, and for us, Tro and I, this is the greatest, for me, it's the greatest learning experience of my life, this podcast. Really, I've learned more in this podcast than all my years of med school, all my years of undergrad, and Avogadro's number and chemistry and all that stuff, and biochemistry, and like we learned because these are real people talking about real stuff, real patients. Some will say these are just anecdotes, but these are real patients to us in real lives that we hold their hands and we look at them, and we want to give them the best life they can. This is why we went into medicine. We're living our dream right now. Tro, close us, man.
No, amen. Look, everything you guys are saying, I'm going to tell you right now, the minute his practice is open, I got 5 patients waiting for him, and if not more. And the fact that we have I'd say, brother in arms in Florida, I can't tell you, we've had at least 5 to 10 patients literally drive or fly from Florida. And I can just say, you don't have to do that. There's somebody who can manage your cardiovascular health. 2 of them had heart attacks, right? What better patient to give to you, Dr. Ovadia, Philip, than somebody who needs that intellectual support to navigate cardiovascular disease. So I'm excited for you. I think you give us credibility, and I can't wait to be, supporting you and what you're doing.
Yeah. Plus you have the coolest logo so out there,
Brian. Man. Thank you, Tro. Thank you, Brian. I look forward to continuing this conversation and to working with you guys and helping to further the community in any way I can.
Awesome. Thank you. It's an honor to have you. Thank you for joining us. And everyone listening, we went a little long. Guess what? This is all valuable information. This is one you're going to want to take to your cardiologist, to your doctor, and say, okay, listen to this cardiothoracic surgeon, see what he has to say, right? It's just these 2 nutty internal medicine docs talking about it. So I think it's really important. I think the more we experience, and when you're looking inside someone's heart and you're looking at those vessels, you want to have an answer. And Dr. Ovadia was, had the courage to look at it and say, wait a minute, what am I doing here? Let's fix this before. Let's change your oil before you blow up your engine. And I got to do a total engine replacement, which is what he does. Let's try to prevent it first. So that's an awesome doctor, in my opinion. And so everyone, thank you for listening. Thank you for your support. And we've been blown away. Even the last couple of weeks, we've had a ton of Patreon supporters join us, and we're honored to have you. Thank you. Thank you for believing in the cause and helping, because you're helping us to maintain our integrity and not take outside funding. So thank you all, and thank you for listening. We greatly appreciate you.